Good afternoon. Welcome to the St. Paul's Health Innovation Series, the Compassion and Innovation event. I'd like to acknowledge with gratitude that we are coming to you from the traditional, ancestral, and unceded territories of the Coast Salish peoples, the Musqueam, Squamish, and Tsleil-Waututh nations. We've had a late change in our program. Fiona Dalton, President and CEO of Providence Healthcare, was to be our moderator, but unfortunately, Fiona's been called away. With Providence, Fiona leads a major health system, with St. Paul's just being one of 17 sites. So this happens on occasion, and Fiona does send her sincere regrets. But we do have the rare opportunity of having with us other Providence and St. Paul's leaders, and they are very much looking forward to this time with you. And I have the pleasure of moderating. I'm Ivone Martins, the Chief Innovation Development Officer with St. Paul's Foundation. We're delighted to come together to bring you this event, and I'd like to assure you that while we're together in a studio, we're being safe and following Dr. Bonnie Henry's guidance. I'll also note this webinar is being recorded, so we can share it with those who weren't able to attend, but only the presenters are on camera and everyone else is automatically muted. After hearing from our speakers, there is a good portion of the program set aside for you to interact through questions and an answer session. We're using Slido, so you can submit a question by going to slido.com and entering our event code. That code is HIS 2020. Please feel free to submit your questions as you think of them. You can also upvote the questions other people ask. Again, it's slido.com and the code is HIS 2020. Today, we're focusing on compassion and innovation in healthcare. In fact, St. Paul's vision is driven by compassion and social justice. We are at the forefront of exceptional care and innovation. The leaders with us today will give us a view into how they're working to realize this vision now and into the future with the new St. Paul's at the Jim Pattison Medical Center in 2026. I'll start by sharing that compassion is certainly not something new to St. Paul's, and neither is innovation. In 1894, 5 Sisters of Providence traveled across Canada from Montreal to Vancouver, equipped with nothing more than what they could carry to treat the city's sickest and most vulnerable people. Their leadership has inspired generations of caregivers and innovators since. Consider Sister Charles Spinola. In 1918, she invented a machine to warm the ether used to put patients to sleep. The warm gas prevented them from going into shock, and it made them more comfortable. Her machine was patented, sold, and became the standard of care in hospitals for years to come. Her invention also changed the practice of anesthesia. And today, Providence, with the support of St. Paul's Foundation, helped found Canada's Digital Technology Supercluster, a Government of Canada initiative. And so, with that partnership, we're partnering with industry leaders and post-secondary institutions to design, develop, and share solutions to tackle some of the most pressing challenges facing Canada and the world today, including projects to tackle COVID-19. Compassion, courage, and ingenuity, and leadership are defining characteristics of the institution and the people of St. Paul's. And of course, this includes our speakers today. And also in the great tradition of St. Paul's, our speakers are our female leaders. We'll hear from Dr. Maylin Bissonnette via video. And here with us live are Dr. Jasmine Grewal and Dr. Anita Palepu. We'll start with Dr. Palepu. Dr. Palepu is the head of the Providence Healthcare Department of Medicine and a scientist with the Center for Health Evaluation and Outcome Sciences, otherwise known as CHAOS, and also at St. Paul's. She's an award-winning educator and mentor and an internationally recognized researcher. She's also an associate editor of a prestigious medical journal, evaluating more than 350 articles per year. Dr. Anita Palepu.
Thank you so much. Throughout my career, I've worked with residents and medical students to care for patients admitted to the hospital on the internal medicine clinical teaching unit. These are the patients who come to the emergency department and are too sick to go home. Increasingly, we are seeing patients with multiple medical problems which are quite complex. I joined St. Paul's in 1996 as new faculty with the University of British Columbia, and I'm a general internal medicine specialist. In September 2019, I became the UBC Head of Medicine, and I'm the first Head of Medicine from St. Paul's, as well as the first woman. I'm also the PHC Head of Medicine, and I took this position to ensure that UBC and Providence Healthcare would be closely linked in the exciting redevelopment of St. Paul's Hospital. As an aside, I'm probably the shortest head of medicine in the country, rounding up at 5'2". People often ask, what is general internal medicine? Well, general internists provide comprehensive care of adult patients in an integrated fashion as opposed to an organ-centered or disease-centered approach. We care for patients with multi-system disorders over a long term or during physiological stresses like during pregnancy or the perioperative period. We take care of patients both in hospital and in the outpatient clinical setting. So in the hospital, we probably take care of most of the inpatient medical patients. We recognize that the practice of medicine is closely linked to the art and science of healthcare delivery, and we are uniquely placed to engage in quality improvement, patient safety, and healthcare system initiatives. During this COVID pandemic, physicians in the Department of Medicine have been frontline in caring for the patients on the wards and on the ICU, and more recently in the outpatient clinical area, and I will tell you more about this later. We are very excited about the opportunity to transform our care to be more and more patient-centered. The new St. Paul's will be an amazing state-of-the-art campus, but what really sets it apart will be what sets St. Paul's apart already, the constant striving to live our values in the care we provide. This will help us achieve the goal of providing truly patient-centered care. This is hard work that we cannot take for granted. Let me outline the components of patient-centered care. The mission and values of the hospital are aligned with patient goals. I can assure you that this is the case at Providence, and it is embedded in our strategic priorities. Care is collaborative, coordinated, and accessible. Physical comfort and emotional well-being are our top priorities. Patient and family viewpoints are respected and valued. Patient and families are always included in the decisions. Families are welcome in the acute care setting and other settings, except right now during COVID, and we hope that will certainly change. Full transparency and fast delivery of information is something we strive for. We are already on this path, and we want it to be fully realized when we move to the new St. Paul's, because it's really not enough to have a shiny new building. It is what goes on in the building and the care that we provide that will make the difference. The building is the structure and the enabler for us to deliver this type of health care. How we get there makes a difference. We get there by being collaborative in the way we communicate and support one another. As healthcare providers, we are responsible for being up to date on the evidence informing the decisions and recommendations to our patients. That is the scientist in all of us. How we communicate and support shared decision-making with patients requires us to embrace some important values and practices. I want to tell you more about the values we need to live to ensure we deliver patient-centered care. In order for us to build relationships with our patients and effectively work in teams, we must have empathy and compassion. I'm sure you hear about empathy a lot in the lay media, and it's a topic of many scholarly articles. I ascribe to the Stanford psychologist, Dr. Jamil Zaki's description of the 3 components of empathy, which include, number 1, emotional empathy, which is kind of like catching the feeling of another person. It doesn't mean that you've had to have had the exact same experience as the person, but you can draw from your own life to have a sense of the feeling. It is making a connection. I had an experience recently where my friend shared that he had metastatic cancer. He felt lost, sad, and had a sense of no control. Although I've never had such a diagnosis, I've had those feelings before, but for different reasons, and could then connect with him. The second type of empathy is cognitive empathy, basically being able to put yourself into someone else's place and see their perspective. It's figuring out why they're feeling what they're feeling. Compassionate empathy, or what we think of as compassion, is feeling someone's pain and suffering and having a desire to improve their well-being. Sometimes that means just listening and letting the person know that you are there for them. As Dr. Brené Brown states, compassion is not a virtue, it is a commitment. It is not something we have or don't have. It's something we choose to practice. It may surprise you to learn that these 3 components of empathy are not processed in the same part of the brain, but rather in 3 different locations. We need all these muscles in our brain to be flexing in order to actualize empathy and compassion. This is a mindset that we have to practice in order to achieve relational healthcare versus transactional experiences. Trust in healthcare is critical. Trust is defined as having the confidence, faith, or hope in someone or something. When patients come to hospital, they want to be able to trust that they're getting the best care possible. When you feel sick, you feel incredibly vulnerable, and your world becomes filled with uncertainty and lack of control. As providers, we must recognize this, respond with compassion, clear communication, and build relationship. Trust is our responsibility, and we must be accountable to the quality of care we provide. In order for you to trust us, we have to cultivate humility. This can be hard for physicians because we've spent almost a decade or more honing our expertise in a specialty. Sometimes we make mistakes of generalizing our expertise to other areas. When we make errors, we have to disclose and learn from them. Humility is being open to learn, come together, and make change. We are practicing this and recognize that an openness to learning is critical for us as an organization to help the patients we are here to serve. To that end, we at Providence have made a commitment to Indigenous cultural safety and recently hired a new director in Indigenous wellness, reconciliation, and partnership to help lead this. It is our responsibility to ensure that physicians and learners recognize that humility is fundamental to Indigenous cultural safety and to continuous quality improvement in our system. Let me give you some examples of how we are working to live our values. The first has to do with our important educational role. At St. Paul's, we train hundreds of learners each year through our affiliation with the UBC Medical School and the residency training programs. Doctors come from all over the world to learn from our physicians in various specialty areas. We take this responsibility seriously. Ensuring that the clinical fellows, residents, and medical students are exposed to these values is critical for the future of patient-centered care. Our patients are often complex both medically and socially, and we work in teams in order to deliver the care that they need. It can be a lot for students to process. I just finished a week on this clinical teaching unit, and as their supervisor, I set the tone for the team in terms of how we interact and create an environment where they are comfortable to ask questions and to help patients get the information they need. Patients often appreciate how the trainees are their advocates by ensuring they get the investigations and results in a timely manner. They explain things to patients and help them problem solve issues. The second has to do with how we do outreach to communities throughout British Columbia. Many of our physicians do outreach to patients with specific and complex diseases throughout the province. With the COVID lockdown, we were able to pivot how we deliver care and growing adept in virtual care. This will improve accessibility to a broad range of patients and support healthcare providers across British Columbia. We have specialists who provide outreach to smaller communities from various areas like neurology, cardiology, which you'll hear more about, general internal medicine, and rheumatology as examples. I know these experiences are important for us as providers to understand where our patients come from throughout the province. The outpatient section of the new St. Paul's will be programmed for interdisciplinary and multi-specialty team care. This will allow patients to be thoroughly assessed with fewer visits, and some of the follow-up can now be done virtually as needed. We are embracing a collaborative model of care delivery. We are responsible for ensuring our learners gain the necessary competencies in virtual and team-based care. Providence is an optimal place for this to happen. Finally, I want to tell you about a recent development that illustrates how we're working to provide patient-centered care and be a learning health system. COVID-19 is a new disease that we do not have a deep understanding of. UBC, Simon Fraser University, and various health authorities, including Providence, are currently collaborating on improving care for patients affected by this novel disease. There are many patients who have survived the initial infection and unfortunately continue to have residual multi-system symptoms. Initially, patients who were hospitalized were seen in follow-up by the respirology service at St. Paul's and at BGH. They quickly recognized that COVID was causing problems beyond the lung. As you know, we have substantial clinical, educational, and research expertise among healthcare providers at St. Paul's. So, we leverage our expertise and use the principles of a learning health system to develop a post-COVID recovery clinic that has patient engagement, standardized data collection, and various ways of being assessed, in person, virtual, as part of the follow-up. This post-COVID recovery clinic is being launched at St. Paul's and at VGH under internal medicine, and we hope to create a network throughout the province for patients recovering from COVID supported by virtual care. Physicians and researchers throughout the organizations have collaborated to make this happen. We are learning from our patients as partners. They are teaching us. This is why we want to lead the path to patient-centered care, so that we can learn together. We need our patients to help us find the right balance of virtual and face-to-face care. We want their input on what is working and what is not working for them. It is critical that we ensure that the next generation of physicians can first hold values that we know are crucial to provide excellent care and be adept in working as part of a high-functioning team for our future of our learning healthcare system to be both sustainable and high quality. I ask that you come on this journey with us. Together, we can transform the care that we provide. We want your engagement in terms of feedback, ideas, and support. Please join us. Thank you.
Thank you, Anita, especially for the call to action for all to participate in the transformation of care. Next, we have Dr. Jasmine Grewal. Dr. Grewal is a cardiologist and the medical director of St. Paul's Adult Congenital Heart Program. She brings invaluable insight and expertise to improve the quality of life and the quality of care for adults living with congenital heart disease. She's also the director of St. Paul's Innovative Cardiac Obstetrics Program, an echocardiographer, and an associate professor in the Faculty of Medicine at the University of British Columbia. Dr. Jasmine Grewal.
Thank you very much. I'm very excited to be here today because I have the opportunity to speak to you about a program and a patient population that is extremely important to me. Now, most of you watching likely know that St. Paul's is a dominant force in cardiac care, and some of you may know that from firsthand experience. But what you may not fully appreciate is the complexity of care that we provide to patients with cardiac issues. For example, patients with congenital heart disease. Now, 1 in 100 babies is born with congenital heart disease. That means that whether you're aware of it or not, you know someone with congenital heart disease. More importantly, a good proportion of these patients require some form of intervention or surgery to survive. Now, times have changed. It used to be that a child with congenital heart disease was occasionally lucky enough to survive to late childhood or the early teens. But that was under the best of circumstances. And now we've had major advancements in the area of medical treatment, surgical interventions, interventional interventions, as well as team-based approaches. All of these have helped so that these children are now surviving well into adulthood. So much so that although the number of children born every year with congenital heart disease has remained about the same, the number of adults with congenital heart disease has grown exponentially. So that today, the number of adults with congenital heart disease across the globe exceeds the number of children with congenital heart disease. Now, at St. Paul's Hospital, we house the Provincial Adult Congenital Heart Program, known as the PATCH program. Our vision, our mission is to care for patients, their families, and staff, while we lead the way in clinical outcomes, research, education for adults with congenital heart disease. Now, this requires an expert team approach, and there have been 11 national centers of excellence established in Canada, and the Pacific Adult Congenital Heart Program, or the PATCH program based at St. Paul's Hospital, is one of those. A hub here at St. Paul's Hospital, it was recognized very early on that care of such complex cardiac patients really requires a multidisciplinary team. We need to treat the whole patient and not just one organ. And we've always believed that we have to treat the entirety of that patient's life. So our multidisciplinary care model includes cardiologists, includes subspecialists within cardiology, adult congenital cardiologists. It also includes specialists from other organ specialists, such as nephrologists, hepatologists, but includes social workers, psychologists, nursing, so that we all work alongside with one another to provide the best patient care possible. Now, at the PATCH program, we're seeing younger patients as they transition from Children's Hospital into an adult hospital, who we help support manage their congenital heart lesion while they live to become adults, while they pursue careers, figure out what it is that they want to do in life, travel, play sports, have relationships, and have children just like anybody else. Now, this is a young lady, a lovely young lady, who was a patient at the Patch program. Now, in 2016, she was 26 years old. And you can see that she's very similar to any other 26-year-old. She looks healthy, she's attending the gym, she's posting for selfies, she's figuring out what she wants to do with her life. And so at that point in time, she was being seen every 8 months or so through the Patch program, doing very well. Unfortunately, things started to change. She started to develop complications from her cardiac condition, her congenital condition. So that in 2019, she wasn't quite the same. She was requiring follow-up every 3 months, had a few admissions to hospital for interventions, had to go on disability. But with our team-based approach and us working with her, we're slowly working on the road to recovery so that she, again, is what she was in 2016. Now, the Patch program works very hard to establish strong clinical care, relationships with the patients. We're also a leader in terms of research, innovation, and education, and that's allowed us to basically collaborate internationally. We also recognize that our patients are young and busy, and as I've already said, they're working to not only live with their cardiac condition, but to live a quote-unquote normal life. And so what that means is that we're working very hard to establish virtual health and outreach so that we're able to serve them in their own communities and they're not having to come down to St. Paul's Hospital for their ongoing cardiac care. Now, these children who are born with congenital heart disease are followed very closely through BC Children's Hospital or through their pediatric cardiologists in the community in an outreach format. And then when they hit the age of 18, they all of a sudden need to transition. All of a sudden they've become an adult and they need to attend an adult hospital and do adult things. This can be quite daunting for many of these children. So with the Patch program, we focus on transition initiatives to ensure that there's a smooth transfer of care from BC Children's to St. Paul's, to ensure that these children become young adults who are comfortable with receiving care in the adult setting and aren't lost to follow-up. Some of these initiatives have included websites, patient forums, and recently we've also established a role for transition coordinator to make sure that patients aren't lost to follow-up and that all of their questions are answered and their families' questions are answered. We've been a leader and created national websites and smartphone applications for specific congenital heart disease patient populations to provide education and resources for patients and healthcare providers in their community so that they're able to look after these patients in the most effective and safe way possible. We are leading many multi-center research studies with the support through peer-reviewed funding, through Heart and Stroke, and through CIHR. And I'm going to end by showing this drawing, which I've kept. One of my patients shared this with me, that he drew it at the age of 11 before he was going in for a cardiac surgery. And it was a cloudy day for him. He was going in for surgery. He came through the surgery, and all of a sudden he realized that his heart was mended, at least for the time being, and sunny days were ahead. This picture constantly reminds me of the great strides that we've made, not only in the area of adult congenital heart disease, but in cardiac disease in general. But it also reminds me that we have a long way to go, and that if we want to continue improving the quality of life and survival of these complex patients, that further research and innovation is required. Innovation in cardiac care, innovation in healthcare is not a budget line item. At St. Paul's Hospital, we've never shied away from confronting a problem that we identify. If there's a need, we try to find a way to meet it. If there's a gap, we try to fill it. But that kind of innovation comes from donations, from people like you who believe in what we do, and often who have experienced it in person. Thank you very much.
Thank you, Jasmine, for showing us some of the excellence and leadership in your area, and also the drive to do even more. So next, we're going to be transported virtually to the laboratory at St. Paul's for a behind-the-scenes look at one of the busiest, most advanced labs in Western Canada. It's a long and impressive list of firsts and onlys. It serves the entire province of British Columbia, as well as the Yukon, and it's home to some of the most advanced equipment and testing protocols in the world. Our guide is Dr. May-Lynn Bissonnette. Originally from Chicago, Dr. Bissonnette is a renal pathologist. She's an MD and a PhD, and she's the director of the Provincial Renal Pathology Lab located at St. Paul's. Let's begin the tour.
Hi, I'm Dr. Maylin Bissonnette. I'm the director of the BC Provincial Renal Pathology Laboratory here at St. Paul's Hospital. So St. Paul's is the home to several provincial programs. There's the IBD and colorectal program for cancer. We are also a major site for breast cancer, where we process and diagnose 70 to 75% of all the cases in British Columbia. And St. Paul's is also home of several very specialized provincial programs, including the cardiac pathology program as well as the renal pathology program. Our lab houses the only clinical electron microscope for all of British Columbia. In our lab, we use this microscope to look at very small structures and cell types for all kidney patients in British Columbia, but also all heart patients in British Columbia, as well as in the majority of patients with nerve issues, muscle issues, and we'll also be looking at different substances within the blood to help a lot of other patients throughout BC. So with the current pandemic, we've accelerated our access to telehealth tools, and pathology is no exception. Now with these virtual tools, we are able to provide connectivity not only to the kidney doctors at St. Paul's, but also to all the kidney doctors in every health authority in all of British Columbia. So this is just one small part of our larger integrated digital pathology plan, that with the ability to have full digital scanning of all of the slides that we produce for every kidney patient in British Columbia, we'll be able to easily show not only the current biopsy, but if the patient has had previous biopsies, to bring that up on conferences to show how things have changed, how things have improved, if treatment is working, and what kind of changes we need to look at. This also ties into how we would accomplish research. So we are very fortunate in British Columbia that we have a very unique program. With these digital pathology tools, we would truly create not only a first-in-kind program for British Columbia, but also Canada and North America, because we would have this fully integrated digital system for pathology where we can easily bring up all these images and have high connectivity. Additionally, we work so closely with nephrology that we have all of the clinical information easily available. And so through this, we are working on creating a fully integrated biobank where there is clinical information, all the biopsy tissue, all the biopsy digital information, as well as all of testing values, so that we can easily look at research projects to improve patient care, new molecular techniques for transplant patients to better recognize rejection, and we can be involved even more in clinical trials that can bring new treatments to the patients of British Columbia. So the overall vision for our lab is to use all of these digital tools to create a fully integrated program where it's not just lab and clinicians, but we are one unified collaborative team. We would like to work on patient-centered tools so that by using these pathology images, patients are better able to understand their kidney diseases.
Thanks to Maylin and the team for showing us some of that leading capacity that really underpins so much of the work done at the hospital in communities across BC and beyond. And now we have some time for a chat with Dr. Palepu and Dr. Grewal to go a bit deeper. And again, I'd like to thank you for your presentations earlier. So much excellence to speak to. And Anita, starting with you. So what is it about Providence and St. Paul's that enables people to come to work and bring their creativity, their ingenuity, and even in times of extreme pressures like they're facing now with COVID-19?
I think the culture at St. Paul's probably is the main reason people have been able to come together. I think also the size of the hospital allows us to have relationships with one another in different divisions and in different departments. You tend to know who people are. So scale is important. I think the values are permeated throughout. We do have a very diverse group of patients that we care for, and they're quite unique for across the country. And we build the skills to be able to provide compassionate care to them. I mean, the mission of social justice does infuse throughout the organization, and we feel it. And I would say the other thing that's been more recently wonderful for our staff has been around engagement. So physician engagement has been increasing, and I think that's also helped us be resilient during this challenging time.
Wonderful, thank you. And Jasmine, as a cardiologist, you're with people at the time when they're most vulnerable, also most hopeful. So when you're providing that compassionate care, how do you create the space and resources you need to also improve care, to continue to innovate?
I actually think that this goes back to the culture of St. Paul's Hospital. Okay. So I think that there is, at an institution level, a real recognition and emphasis of the importance of a truly multidisciplinary team-based approach. So no one person can do all of it alone. And so if I take the PATCH program as an example, we truly are a multidisciplinary team. And so although I'm a researcher and I love my patients, I couldn't do what I do if it wasn't for my nursing colleagues, and if it wasn't for my, my psychology colleagues, and if it wasn't for the other cardiologists that I work with. So I think we all work together, and we all focus on different areas of importance. And by doing that, we're able to grow our program, we're able to innovate, do research. But when we all take on those different roles, we can all ensure that we provide excellent patient care. And that's sort of a common base denominator, that we all work very hard to do that, while the team does, different aspects of that. And I think that that's really what facilitates that. But again, even for that to happen, it's buy-in and support at an institution level, and an understanding that this is what needs to happen. So I have to say that we have a huge amount of support at an administrative level, that this is how we should be looking after our patients, and allows us to do our job.
Thank you. Thank you. And now I understand we have a board member from St. Paul's Foundation in the virtual audience. I'd like to introduce her and to get her thoughts on all this innovation that we're talking about, and what it might look like when we move to the new St. Paul's. Now, Norma Sebastian enjoyed a long career in biopharmaceuticals with Merck. She now applies that experience as an advisor and board member to organizations in health and life sciences. Norma volunteered to be part of the foundation board just this year. And Norma, given your background at one of the world's most research-intensive pharmaceutical companies, particularly with its emphasis on medicines and vaccines, tell us, what made you want to be part of the St. Paul's Foundation and the journey to the new St. Paul's?
Thanks, Ivone, and to the physicians for sharing their knowledge and innovation in care at St. Paul's. Hi, my name is Norma Sebastian, and as mentioned, I'm delighted to recently join the St. Paul's Hospital Foundation Board. And that's after a 26-year career at Merck, all in the area of health innovation and biotechnology. Ivone mentioned I'm still involved in a number of boards, particularly national research institutes that are really focused on innovation and scientific discovery in Canada, as well as even small sort of digital health companies that are all about improving patient care. The reason I wanted to join the foundation board is that I really saw in my career time, in the years, firsthand what St. Paul's was doing locally and globally in terms of advancing health innovation and research through partnerships and collaborations. I saw this when I was at Merck. We would scan the world for the best innovations that we could collaborate with, and we often ended up at St. Paul's in Providence. I also spent 6 or 7 years on the Providence Research Institute Board, which is at the core of St. Paul's in terms of research and innovation and bringing it to the bedside. And I saw many, many innovative discoveries transfer to patient care when I was in that role. I have to mention a few that I saw when I was at Merck, whether it was a new discovery that actually advanced heart and lung research and how patients were going to be treated, to new treatment protocols for combined cardiac and kidney disease patients, much of the type of patient Dr. Palepu just was speaking about with us. And also treatment protocols for patients living with HIV and hepatitis. Many of these innovations and the results that were identified and discussed became global treatment protocols that have been used in the past and continue to be used in the future. This is really at the foundation of St. Paul's and the compassion and social justice that I've experienced as I've been involved in institutions globally around the world. With the new St. Paul's at the Jim Pattison Medical Center, there's really an opportunity to build on the legacy at Providence and to create a globally recognized health and life sciences ecosystem, similar to what we see in Silicon Valley in the tech world, all but in health sciences.
Norma, and what would you say to donors, community builders, and corporate leaders about the impact the new St. Paul's will have?
Well, at the new St. Paul's, we're really envisioning this new health innovation hub, and it will attract life sciences companies across the whole ecosystem, biotechnology companies, data companies, IT companies, VR, AR companies, digital health companies, all about bringing all these innovators together to impact patient care and outcomes. This impact will really resonate well beyond just the hospital. It will bring together the entire community, the business and government, research institutions, all of it, global companies, into one core center. This was really important in the past, and now we're in this new reality with the pandemic, and it's even more important as a catalyst for change in healthcare and economic recovery. So I say to anybody that's listening, to anybody that's involved in the community, St. Paul's, or in our whole community here, get involved. You do have something to contribute, and it's really once in a lifetime opportunity to be part of this journey. And it really is only through the support and generosity of the community that will create this center that's a catalyst for health innovation and impact our community here in British Columbia as well as globally. I thought I had a question. Is that okay, Ivone, that I would bring to possibly to Dr. Palepu?
Please.
So I mentioned expanding healthcare system. So what I'd be interested in knowing is how, with the various innovators in the ecosystem, how this can be translated into patient-centered care, which is at the core of what she talked about and at the core of St. Paul's.
Thank you, Anita.
So I think we want to be a learning healthcare system, and we want to really trial new models of care with partners in various sectors. So I see that probably happening in what we hope will be the Clinical Support Research Center, to have the space where we can do simulation of those models and test ways of delivering care and do that pilot work before we actually go out to patients. That's sort of how I see it, as being something that we integrate our partners into and ensure that, that our missions are aligned. That would be also very important. Thank you.
And Jasmine, would you like to add to that?
Yeah, the only thing I would say is that I completely agree. And I think that when we look at particularly complex patient populations, so for example, the congenital heart population or other complex cardiac populations, you know, no one population is exactly the same. So even within that population, patients can be quite different. There's heterogeneity. And it's not always easy to study these patients, especially when we're thinking about interventions, whether they be, you know, surgical type interventions, whether they be, you know, percutaneous valves or pharmacologic therapies. The patients are quite different from one another. So I think, you know, the new St. Paul's will allow for that kind of collaboration, adjacency, you know, and sort of trialing and piloting different interventions in a very systematic way, but brings all the right players in line. So I think it'll facilitate that kind of work.
Outstanding. Now I see that you've both inspired a lot of questions. They're already lined up waiting for you, but there is still time to submit more. Just go to slido.com and enter our event code HIS 2020 if you'd like to add a question. So let's start. So maybe I'll start off and just ask, if you had no barriers, what would you do to improve patient care and outcomes? It's a big one.
I haven't had a chance to dream in Technicolor for so long with this pandemic, so that, you know, first of all, if I could have no barriers, I would want to see a vaccine for the pandemic, you know, for the COVID-19, and I think that would just sort of be a start for us, because I think we need to get out of this difficult situation. The other thing that, if we had no barriers, I think it's really to establish the resources that our patients need to be healthy, and that happens in hospital, but also happens outside of hospital.
Yes.
And having a really strong partnership with the communities that our patients live in and making that real. And so that we can infuse the values that we have as an organization internally out into the community.
Thank you. Dr. Grewal.
Yeah, I would say that if there was no barriers, it would be to do anything and everything that we could do to improve access of care for our patients. So for those individuals who, you know, whether it's a financial barrier, and they could be living in Vancouver, but there's financial barriers, you know, or social barriers, or whether they're patients that are living far up north that can't access the services that they need for a variety of different reasons. And so it's to put into place, you know, all the different things that we would require to really overcome that access to care. Because I think once people can access the care that they need, you're going to see an improvement in outcomes for sure.
Definitely.
Wonderful. Okay, so we've got them in order now here, and the first one is there a concern that with the focus on technology at the new St. Paul's, that we lose the in-person empathetic aspect of care?
So I think both Jasmine and I could answer this. I would like to say that this is a reason why I want us to focus on our values, because the values are fundamental for the patient care that we want to deliver. And the technology is one of our tools. It's not the be-all, end-all. And I think that that's the most important thing that we want to convey and really embody in when we say patient-centered care. And I think the patch clinic that Jasmine was describing is a place where that's happening. They really see their patients for who they are and really try to tailor the work that they need. And they do a lot of technological interventions, but that's not the focus. I don't know if you want to say something more.
Yeah, I think what I would say, actually, I agree, is that if anything, I think what the COVID pandemic has taught us, taught our program, taught me, is that there is definitely a place for technology, but it is not the end all and be all. And so, you know, there was a time initially at the beginning of the pandemic where everything we were doing in terms of patient interaction was virtual in the clinic space. And nobody was happy with that from a care provider perspective. Actually, a lot of patients were happy because they didn't have to come into the hospital because of COVID, or they may live far away. But as healthcare providers, the physicians weren't happy, the nursing staff weren't happy. And so what we've actually done, you know, is taken that, what happened at the beginning of the pandemic is to look and see what's the best way to sort of integrate technology or virtual health into our existing clinic. And so it won't be the end all and be all. It just can't be, because I don't think that anyone would be happy providing care like that on a repetitive basis for all patients. I think it has a role. I think it helps to provide access for many patients. And when I think about our patient population that tends to be young or live all over the province, it might be that they aren't coming in for every visit with us in person because they have young children or have work and they can't get off. And there's all these sort of practical kinds of things. But I think there's a role, but it definitely, I don't see it being the only way we function.
Wonderful. So the next question, you've both had such an emphasis on compassionate care. And this question asks, I've heard about compassion fatigue. Is this something you've experienced? How does Providence support healthcare providers to overcome or avoid this? Anita, would you like to start?
Sure. I think Providence is very much aware that we have a hard job, and our patients need a lot of care, both medically and socially, and support. The one thing is that I feel like we work in teams, and I think that helps strengthen us. And when you work in teams, you don't feel alone. You can debrief, and you have to constantly work on taking care of yourself. And I think, like, as time has gone on as a provider, that's something I've recognized, and I try to emphasize that with the younger physicians who come on board. So I think it is possible to have compassion fatigue, but I think that's really a function of a system that doesn't take care of you, and we are working really hard to take care of our nursing staff, our physicians, our allied health, and it's really about teamwork in the end. So.
Yep. I think that as teams, we support each other. I think it's very important. And so it's like any professional or personal relationship. You know, there's going to be some days where someone's going to be towing the line and another day that somebody else is. And I also think there's a component, and this is part of the training, is that, you know, Dr. Palepu had spoken about emotional empathy and cognitive empathy. And so a lot of times there's a lot of emotional empathy at play where we truly, try to understand our patients and put ourselves in that position and really sort of feel where they're coming from. Now, we can't always do that, in part because of compassion fatigue, but I think that's where the cognitive empathy sort of kicks in. And so you're always aware that, that your patient might be going through something very difficult, or you're trying to help them through that. And you use different tools to help that interaction, and they might not always be the same.
We're very glad to hear there's things in place to take care of you and all the other caregivers at St. Paul's. So the next question we have is, does innovation play a role in implementing patient-centered care? Please go ahead, Jasmine.
I would say that it does. I think that, again, I'm going to speak to this from being the director of the PATCH program. And that is that, up until recently, our patients were sort of, they'd come down to Vancouver, they'd be here for 3 days, they'd get all their testing done, we would see them. But it wasn't always patient-centered, because it may not be what the patient necessarily wanted or could do at that time. And so now we're having conversations around, you're a moderate risk patient, and this year you could either come down for all your testing and we could see you, or you could maybe have your testing done next year because we hear that you're doing well, and maybe we could do a virtual health program. What would you be comfortable doing? And so we give patients that choice. And so I think actually in many ways that's more patient-centered, because if we feel that it's safe to have one of 2 or 3 different options, then the patients can decide based on what's happening with them personally or socially at that time in their life what actually works. I think the other thing is that with innovation, we're able to bring care to them. So when we think about outreach, again, that's very patient-centered. And when we think about, applications on smartphones or websites, a lot of stuff that we're working on right now, all of that is patient-centered. So I think innovation definitely plays a huge role when it comes to patient-centered care.
We'll move on to the next question. And someone is asking, how can I help support innovation at the new St. Paul's?
Go ahead, Jasmine.
Sure. I think maybe the first step is sort of accepting or understanding, and I think our audience does, that innovation is important. And so then I think the next step is being engaged, in whether it's volunteering your time or whether it's a donation. As I said in my presentation, innovation isn't a budget line item, and I've recently just learned of this as I took over this directorship. I was kind of oblivious to a lot of the administrative side of things. But I think that, whether it's time or whether it's donation, I think everything helps to support innovation, or whether it's your personal expertise or experience that you've had and bringing that, whether it's as an expert in innovation in a separate sort of domain, or whether it's as a patient who's experienced it or has some thoughts around it. I think there's lots of different ways to contribute to innovation at St. Paul's.
Thank you. And certainly St. Paul's Foundation is fully equipped to support anyone's interest in bringing support to your areas and across the hospital. So thank you. And the next question is, how does a new hospital on the horizon and new models of care influence the curriculum of learners? Anita, maybe you'd like to take this one since it's such an emphasis for you.
Sure. So we are one of the large teaching hospitals for the University of British Columbia, and we train the medical students as well as residents in various specialty areas. So in terms of new models of care, we want to be leading in that area and give our learners that expertise. The curriculum, it's a bi-directional thing. We'd like to influence that, and I think we are a wonderful place for the care to happen. With regards to specifics, one thing is more and more interprofessional collaboration, which is already happening, and we can have an opportunity to make that more formalized and be a space where people can come and have more interprofessional education together. So I think the learners will have an incredible experience at Providence, and they often comment on that this hospital is a place where they make memories, most of them good. Sometimes when they're on call it may not feel that way, but I think that the new models of care that we want to see, the learners are going to be integrated in that experience, and that is really powerful for them.
Thank you. And our next question is, does your team have a collaborative and patient-centered approach to research, and what does it look like? Dr. Grewal, you've spoken so much about the multidisciplinary and the multi-person team. Would you like to answer this question?
Sure. I think it's a really important question. And I think it's something that we as medical professionals have sort of recognized over time and have worked towards over time. So if I look at our research team, I believe that it is patient-centered, our approach, and that we're collaborative, and so that any given research study or proposal, whatever we have, involves nursing, it involves our clerical staff, but I think most importantly involves the patients. And so we try to integrate our research into the clinical realm. And so there's going to be some forms of research that are truly not things that can be embedded within the clinic, but I'd have to say that the vast majority of it is integrated into the clinical workflow, so that it's something that our team is all aware of, something that our team is able to communicate with our patients, whether it's at the physician level, nursing level, clerical level, and that we, as we sort of pursue different research projects or proposals, it's so important to have our patients involved in that process. And so when we think about research, we think about knowledge translation, and we think about asking our patients, what's important to you? What do you think are the important questions that we should be answering? And so having, you know, one or two patient representatives on any sort of research proposal and research sort of think tank. And I can give you an example. We have, we're collaborating with neurology team that it's looking at sort of neurocognitive concerns that might arise in the congenital heart population. And so we've worked very hard to establish a patient forum. And this is not a part of the research project. This is actually a lead up to a research project where our patch patients are all invited to attend this forum. And the intention is to provide some educational material, answer questions, but then also ask our patients, what's important to you? Has anyone ever spoken to you about the neurocognitive issues that might arise? And what do you think would be important to answer? And so very much we're trying to integrate our patients into the research process.
Wonderful. And we have another question for you, Dr. Grewal. What are you most excited about for the future of the PAC program?
There's many things. There's our team is growing, and every individual in our team is bringing something extremely important, and whether it's an interest in education, whether it's an interest in technology or research. And so I would say there's a lot of things that I'm excited about. But I think what I'm really excited about is us being able to provide more patient-centered care. And so it actually goes back to innovation, and it goes back to outreach and virtual health, and it's making access to care easier for our patients. And if I give you another example, you know, when the COVID pandemic started, you know, we spent a lot of time in our clinic trying to reach our patients, and sometimes, you know, they may not come in for 3-4 years. A lot of it's due to social reasons and access to care. But when we started virtual health, because we had no choice, and it was made much easier for us during this time period, the number of patients that came out that we weren't able to reach for years, who we were now conversing with via virtual health, it was a blessing. And so I think what I'm most excited about is improving access to care, and I think innovation in virtual health is really going to allow us to do that, so that we're not having patients who are, you know they really want to come in, but they can't come in. So we're able to help them in that way.
Wonderful. Now, Dr. Palepu, we'll ask this one of you. What is the thing you are most looking forward to when we move to the new St. Paul's?
I'm looking forward to having enough space to do rounds and teach the residents and students. I will tell you, nowadays, it is so crowded on the medical wards. I am looking forward also to the patients having their own single room, having enough space for them to feel comfortable, for them to have dignity. I'm really looking forward to the physical environment that will enable us to provide the kind of care that we want to, and for the learners to have space to safely talk about issues and not be disturbed every 5 minutes because we're in somebody's way.
And Dr. Grewal, I'm sure you have some thoughts on that too. What are you looking forward to?
I do, but the sort of the first thing that pops to my head is, again, patient sort of dignity and respect, and whether it's a single room or whether it's in a clinic space where patients are sort of coming and going in very close quarters, and there's names on boards, and so really just sort of being able to respect that privacy, that confidentiality, I think is going to be very nice.
Yes, priority. So Dr. Palepu, I think this one is for you, further to what you were speaking to earlier. How do I participate in the transformation of care as a patient?
We are so excited to have you give us your feedback. That's the most important thing that we need. We need to hear from you, and you can do that through the foundation. We also have patient advisory groups that help us with many committees that we have in the hospital, and we would welcome your involvement as well, and if you have a particular area of interest.
Thank you. So we have a number of questions left here. The next one, what do you think is the next step in incorporating technology into chronic disease management and to support patients during transitions like youth to adult care? Well, we know this is your domain, Dr. Grewal, and I'm sure Dr. Palepu has something to say too, but would you like to take that question?
So I think that there is a lot of technology out there that we can use. What I would say is the recognition that many of these conditions, so congenital heart disease as an example, is a lifespan condition.
Yeah.
And so that I think if we take the technology that we have, but incorporate it in a lifespan way, so that it transitions from childhood into adulthood. And so I spoke of a transition coordinator that's come on to help with a lot of these lifespan conditions such as congenital heart disease, cystic fibrosis. And I think ensuring that that technology spans isn't just available for children or adults, but that same technology, that same platform spans from childhood into adulthood, so that really from a patient perspective, things are seamless. Because right now, you know, you may use a particular technology, an app or whatever during childhood, but then it completely changes when somebody all of a sudden, you know, becomes an adult at the age of 18. I think there's a huge gap there. So I think we need to make sure that whatever it is that we're using spans that transition time, that lifespan.
Mm-hmm. And I think the next question is further to that. So what challenges do youth congenital heart patients face when transitioning from BC Children's to St. Paul's Hospital?
They face a lot of challenges. And so, you know, they've lived with this condition their entire life, but they've had their parents by their side, they've had their siblings by their side, and, you know, they haven't really, you know, had to sort of think about it a lot themselves. And so I think all of a sudden, they go from one location to the next. St. Paul's Hospital is not as pretty, at least the current one is not as pretty as BC Children's Hospital. And all of a sudden, they're having to have direct conversations with their physician or the nurses. And so it's not uncommon that when I'm talking to somebody who all of a sudden has turned 18, I'm meeting them for the first time, that, you know, they're looking at their mom or dad, and I'm looking at them, and it's just, you know, so there's a lot of learning that needs to take place, learning about what their underlying congenital heart condition is while they are attending school, trying to get into university, you know, figuring out what they want to do with their life. They're in a relationship. Can I or can I not get pregnant? So there's so much information that we need to provide. And thankfully, many initiatives that are underway that have, you know, sort of come about with collaboration between St. Paul's and Children's Hospital to help facilitate this process. But we still have a long way to go.
Wonderful. More collaboration. So, Anita, if you had more funding, what changes or improvements would you like to make to support whole person care?
So thinking about the patients that are inpatients, I think that we need to do a lot more to support them, because most of them have multiple medical problems, multi-morbidity, and I think we need more support from social work, allied health to help them get better, because a lot of times when people get sick, their whole function declines, and the rehabilitation piece is huge, and we need to support them with that. So that's one thing, and the discharge planning, and ensuring the discharge goes smoothly, and ensuring that transition of care, and also having more support in the clinics so that we can all be practicing at the best level of our scope. I think the Patch Clinic's a great example where it's multidisciplinary and everyone is practicing to their areas and strengths. And so having that infused to all of our clinics would make this be much more whole person, and I think would ensure better outcomes for patients.
Thank you. And Dr. Grewal, you did speak to whole person care. Did you want to add to that?
Yep, so what I would say, if there's one thing that I could choose, there's probably many, but one thing I would say is more support for mental health.
Right.
So we're fortunate in the Patch program to have a psychologist as part of our multidisciplinary team. And I can tell you that she is very, very busy helping our patients, whether it's helping them with some of the sort of personal issues that they might be facing in life that are complicated by their underlying cardiac condition or stress related to an upcoming surgery. But what I would say is if we had more resources for supporting mental health, whether it's a simple medical condition or complex, people have different coping mechanisms, people have different psychosocial situations, scenarios in their life, and I think if we can provide the support from a mental health perspective, that would be very, very impactful for our patients.
Very timely.
I agree.
So, well, I see now we're at close to the end of our time, and those are really great comments to end the question and answer period. So to close, I'd like to extend our deepest appreciation to Dr. Bissonnette, Dr. Grewal, and Dr. Palepu. Thank you. Also, thanks to Norma Sebastian. We're grateful to have such an engaged leader volunteering her time and expertise. We've just been given a small view into how St. Paul's is positioning to transform care, having a uniquely deep integration of care, teaching, research, and innovation, and how this will be strengthened even more with the new St. Paul's at the Jim Pattison Medical Center. Considering what's been accomplished at the current facility, it's really exciting to imagine what we'll be able to do in a new, state-of-the-art, purpose-built hospital and research and innovation hub. So, and most of all, a heartfelt thank you to everyone who has joined us today. We appreciate you taking time out of your busy day to hear from these amazing leaders from St. Paul's. It is our donors, volunteers, partners, collaborators, and champions that have played and will continue to play a vital role in enabling our world-class physicians, scientists, and leaders to innovate, to continuously advance care. And really, you make it possible for them to live their motto, to treat you how you want to be treated. St. Paul's Foundation is grateful for the opportunity to help facilitate those outcomes and that impact. Again, thank you to those in the studio and watching from home. Best wishes for good health and well-being. We look forward to the next time. Good night.